Thank you for joining us today for the webinar New Agendia Data from the ASCO 2024 Annual Meeting, presented by Dr. William Audeh, where he will be reviewing the latest MammaPrint and BluePrint data that was presented earlier this month at ASCO. Before I hand it over to Dr. Audeh, I just want to give a brief introduction about him. He is our Chief Medical Officer at Agendia and is a medical oncologist specializing in breast cancer with nearly 30 years of experience as a clinician and clinical researcher at the Cedars-Sinai Cancer Center in Los Angeles. Prior to joining Agendia, in addition to his clinical practice, he also served as the former director of the Cedars-Sinai Cancer Center and medical director of the Wasserman Breast Cancer Risk Reduction Program. And Dr. Audeh has also been principal investigator on a wide variety of national and international clinical and translational trials, and has authored numerous publications in the field of breast cancer, cancer genomics, and targeted cancer therapy. So with that, I'll hand it over to you, Dr. Audeh, and you can share your screen.
Thank you. So thank you all for joining us today. I'm really very proud to be able to present a review of the Agendia data from the ASCO 2024 annual meeting. As you know, there were two oral presentations of Agendia data, and that's what I will be reviewing this afternoon. These were two abstracts that were derived from the FLEX study data, which I'll explain a bit further in a moment, which were very fortunately selected for oral presentations. The first was presented on Friday, May the 31st, in the rapid oral session for the breast session devoted to local, regional, and adjuvant therapy data. This was presented by Dr. Joyce O'Shaughnessy, who is the principal investigator of the FLEX study, and her presentation was entitled Association of MammaPrint Index and 3-Year Outcome of Patients in the FLEX Registry Trial with Hormone Receptor Positive, HER2 Negative Early Stage Breast Cancer treated with chemotherapy with or without anthracycline. The second oral presentation was on Monday, June the 3rd, in the main oral session for breast cancer relating to local, regional, and adjuvant therapy data. This was presented by Dr. Erin Cobain, who is the principal investigator of the SWOG S2206 study, which you'll hear about more in a moment. And her presentation was entitled Elucidating the Immune Active State of Hormone Receptor Positive HER2 Negative MammaPrint High 2 Early Breast Cancer. Now, since both of these presentations derived from the FLEX study, I wanted just to take a moment to give you an overview of the FLEX study, something which Dr. Cobain also did in her presentation. FLEX is a prospective real-world evidence study designed to support investigator-initiated breast cancer research through the curation of paired full transcriptome and clinical data. This study enrolls patients with stage 1 to 3 breast cancer who have received or are receiving standard of care MammaPrint testing and have provided a tumor sample following informed consent and IRB approval of the study. As you can see on the far left, patient eligibility is broad. Any stage 1 to 3 breast cancer patient, male or female, 18 years or over, with at least one new primary lesion and any receptor status. Exclusion is limited to those with metastatic or recurrent disease or non-invasive stage 0 disease. For enrollment, a patient must have a standard of care, MammaPrint and very often BluePrint genomic test conducted. And the sample that is used to generate the MammaPrint and BluePrint is also analyzed for all expressed genes, and full transcriptome data are collected into our database. This is in addition to extensive clinical annotation with multiple clinical data elements. We follow these patients through their study, through multiple study arms and through their course of therapy and follow-up, whether they receive adjuvant therapy, neoadjuvant therapy, or non-surgical therapy, and follow them through diagnosis, treatment, and collect outcomes, all in a common database accessible to our investigators. So from this database, this particular presentation was derived. This was the association of MammaPrint index and 3-year outcome of patients in the FLEX registry trial with hormone receptor positive HER2 negative early stage breast cancer treated with chemotherapy with or without anthracycline. Now, the basis for this was to address a question that all oncologists struggle with, and that is to determine who really benefits from adjuvant anthracycline chemotherapy. The anthracyclines in early breast cancer trial, known as ABC trials, 3 trials that were collected together in their analysis, showed, as you may know, that docetaxel cyclophosphamide, or TC, was not non-inferior to an anthracycline-based regimen regarding invasive disease-free survival, IDFS, and high-risk HER2 negative breast cancer. However, this benefit from the anthracycline was modest. There was a 1.6% improvement in 5-year invasive disease-free survival and a 2.8% improvement in 5-year recurrence-free interval. But when this analysis was stratified by hormone receptor status, it was found that the main significance for the benefit of anthracycline was found in the hormone negative, and HER2 negative breast cancer, otherwise triple negative breast cancers, with a hazard ratio of 1.90 and a very significant p-value. The benefit for anthracycline was really non-significant for hormone positive HER2 negative patients. Hence the question as to whether genomic profiling could better identify patients in the hormone positive HER2 negative population who may actually benefit from anthracycline. And that was the basis of this analysis. The reason 3-year relapse-free survival was analyzed was based upon prior data that had already been generated regarding the responsiveness of hormone receptor positive breast cancer when stratified genomically by MammaPrint. The MammaPrint 70 gene test, as you may know, provides implications for both endocrine therapy management as well as chemotherapy decision making. What you see here was presented by both Dr. O'Shaughnessy and Dr. Cobain. And this is the spectrum of subtypes within the MammaPrint risk range. Within low risk, there is the ultra low risk range, where we observe no chemotherapy benefit, and endocrine therapy benefit, which may be significant, but which may not require, in this case, a full 5 years of therapy in the event of toxicity. MammaPrint low risk also shows no chemotherapy benefit, but may show extended endocrine therapy benefit beyond 5 years. The focus of this analysis, as well as Dr. Cobain's, however, was in the high risk portion of the MammaPrint range, where we now recognize both high risk 1 from 0 to minus 0.569 in the negative range, and high 2, minus 0.57 to minus 1.0. The differences here between high 1 and high 2 will be further explored in these studies. But what has been observed is neoadjuvant chemotherapy benefit in both of these high-risk categories, indicating prediction of chemosensitivity, but differential sensitivity to agents in high 2 versus high 1, agents such as PARP inhibitors, immunotherapy, and platinum. Now, another major difference, of course, is the likelihood of achieving a pathologic complete response to neoadjuvant chemotherapy when tumors are stratified by MammaPrint as being either high 2 or high 1. And here in the graph on the right from the NBreast trial, you see the increasing likelihood of pathologic complete response as the MammaPrint index goes from high 1 to high 2. In this particular study, 1/3 of the high-risk MammaPrint patients were high 2 and 2/3 were high 1. The data in this particular study indeed showed an increasing likelihood of PCR in the high 2 range. This has been seen actually in 2 other cohorts from iSpy as well as from Flex, as I will show you in a moment, in which high 2 MammaPrint patients that are hormone receptor positive and HER2 negative consistently show higher PCR rates. Here you can see the PCR rates to standard neoadjuvant chemotherapy in all 3 of these cohorts, ranging from 6.1 to 10% for high 1, but more than doubling in high 2 to well over 20%. In addition, in preliminary data presented at the Miami Breast Cancer Conference earlier this year, we also showed that MammaPrint high 2 appeared to be associated with increased sensitivity to neoadjuvant anthracycline therapy when TC versus ACT regimens were compared. Now, among MammaPrint high 1 cancers, the PCR rates between ACT or TAC versus TC appeared to be comparable, with rates of approximately 7 to 7.7% without significant difference between them, as you can see on the right. With the high 2 MammaPrint patients, however, although the numbers were small, it was striking to observe that there were no PCRs observed in the TC arm, while there was a 32% rate of pathologic complete response with ACT. This led to the Flex study that Dr. O'Shaughnessy presented, which was evaluating the 3-year recurrence-free survival based upon patients treated with TC versus an ACT type regimen. The methods shown here, of course, were to review the Flex registry trial database, which, as I mentioned, is a prospective observational study. And from this database, we found 614 patients with hormone receptor positive, HER2 negative, early stage breast cancer who were MammaPrint high risk and very specifically BluePrint luminal B hormone receptor positive breast cancers. This is in contrast to BluePrint basal, in which the biology appears to be more similar to triple negative breast cancer, and for which there does not appear to be intact hormonal signaling. So this was limited to BluePrint luminal MammaPrint high-risk patients. They had to have received chemotherapy and have at least 3 years of follow-up since diagnosis. High-risk cancers were classified, as I mentioned, as high 1 or high 2, and the choice of regimen was left up to the discretion of the treating physician. The endpoint, recurrence-free survival, which was defined as the time from diagnosis to local, regional recurrence, distant recurrence, or breast cancer specific death. And statistical considerations are shown here. Now, beginning with the clinical characteristics of these BluePrint luminal MammaPrint high-risk patients, in this cohort, comparing high 1 to high 2, 86% of the patients, 530, were MammaPrint high 1, while 14% or 84 were high 2. Age, menopausal status, race, tumor stage, and lymph node status were comparable between patients with high 1 versus high 2 versus high 1 tumors. It's important to point out that 56% of MammaPrint high 2 patients were grade 3 versus 24% of MammaPrint high 1. About half of the high 2 patients received ACT, while about a third of the high 1 patients received ACT. And it was evident that high 1 and high 2 patients who received ACT were significantly more likely to be premenopausal and have higher T and N stage, perhaps triggering the selection of ACT versus TC in this cohort. Now, looking specifically at high 1 patients first, treated with ACT versus TC, again, in a non-randomized manner, we show the ACT patients on the left, luminal B high 1 patients by MammaPrint had a 95.3% 3-year relapse-free survival, which was comparable to the results seen with TC, 97.1%, with no significant difference with the addition of anthracycline, at least in this cohort of high 1 patients. This is in contrast to what was seen in MammaPrint high 2 patients, where those treated with ACT had an outcome of 97.7% recurrence-free survival at 3 years, compared with 86.4% with TC at 3 years, indicating that MammaPrint high 2 tumors have been identified to have a worse outcome with TC versus ACT. Now, here's another way the data have been shown, and you can see that for high 1 patients comparing TC with ACT or TAC, there's really no significant difference in the 3-year relapse-free survival, while there appears to be an over 11% improvement in 3-year relapse-free survival when high 2 patients are treated with an anthracycline-containing regimen, improving from 86.4 to 97.7%. So in conclusion from Dr. O'Shaughnessy's presentation, in this real-world Flex registry database with MammaPrint high 2 and BluePrint luminal B subtype, these hormone receptor positive HER2 negative early breast cancers have a higher 3-year relapse-free survival rate when treated with ACT rather than TC adjuvant therapy. Luminal B patients that were MammaPrint high 1, however, appear to have similar 3-year relapse-free survival rates with adjuvant TC compared to adjuvant ACT. Now, the FLEX trial has now enrolled over 17,000 patients as of today's date, actually, and the intent is to continue accrual to a total of 30,000 early-stage breast cancer patients with at least 10 years of follow-up. And these preliminary findings, of course, are consistent with what we have seen in other studies of high 2 biology, in addition to data that was also presented at the ASCO 2024 meeting referred to here. A poster from Dr. Rios Hoyo and his colleagues at Yale and in the I-SPY network, in which they showed that MammaPrint high 2 patients have similar gene expression profiles to true triple-negative breast cancer patients, even though those high 2 patients are expressing estrogen receptor. And then in the presentation I'm about to show you from Dr. Cobain, high 2 patients appear to have an immune-activated state in their tumors. So moving on then, from this, I think the conclusion we can draw is that MammaPrint is identifying a subset of patients identified as high 2, which may benefit from the addition of doxorubicin to standard taxane and cyclophosphamide therapy, and therefore does help to identify those hormone receptor positive patients who may need some escalation of their adjuvant or neoadjuvant chemotherapy regimen. But validation with additional studies is certainly needed and is being pursued. Now, moving on to Dr. Cobain's presentation, elucidating the immune active state of hormone receptor positive HER2 negative MammaPrint high 2 early stage breast cancer. The presentation, as you know, if you attended ASCO, now begins with the conclusions. And the conclusions were that MammaPrint high 2 tumors were shown to exhibit a heightened immune active state compared to MammaPrint high 1 tumors among hormone receptor positive and HER2 negative early stage breast cancers analyzed from the FLEX registry. The presence of these immune cells and the upregulation of genes involved in antigen presentation, which are critical in eliciting T and B cell activation may explain the improved response to immunotherapy that has been observed primarily in the I-SPY trial in MammaPrint high 2 tumors. One of the conclusions that is drawn from this study, as you will see, is that selecting patients with hormone receptor positive, HER2 negative, early stage breast cancer for immunotherapy treatment based on biomarkers such as grade or percent estrogen receptor positivity alone may end up excluding patients that are likely to benefit. And conversely, patients with high grade tumors that are not high 2 may be at risk of experiencing toxicity without clear benefit of therapy. The data that I'm about to show you support the ongoing SWOG 2206 clinical trial, which is evaluating the impact of neoadjuvant chemoimmunotherapy on rates of pathologic complete response and invasive disease-free survival in hormone receptor positive, HER2 negative, early stage breast cancer when the patients are pre-selected to have MammaPrint high 2 risk. So the topic, of course, of neoadjuvant immunotherapy in hormone receptor positive breast cancer is a major source of research at this time. One of the reasons, of course, is that patients with clinically and genomically high risk hormone positive HER2 negative breast cancer continue to have at least a 20% risk of recurrence, despite the addition of current new adjuvant therapies, such as CDK4/6 inhibitors. So there is still room for improvement in adequately identified high-risk hormone positive HER2 negative breast cancers. The addition of immune checkpoint inhibitors to neoadjuvant chemotherapy in hormone receptor positive HER2 negative breast cancer has, as you know, been evaluated in phase 3 clinical trials, the CheckMate 7FL trial and the Keynote 756 trial. However, it's important to note that these trials used clinical stage tumor grade, specifically grade 3 or low estrogen receptor percentage expression, less than or equal to 10%, to select patients for these trials, based upon the assumption that these identified patients with a high risk for recurrence for treatment on this study. The point of this study, and what makes it unique, I would say, is that genomic classifiers predicting recurrence risk, such as the MammaPrint 70 gene signature, may actually offer enhanced precision in identifying hormone receptor positive HER2 negative breast cancer patients who benefit from chemotherapy and the addition of immune checkpoint therapy. Now, Dr. Cobain reviewed the implications for the various MammaPrint risk categories, and I won't review them again, although what she also did was to reiterate the data that had been presented earlier by Dr. O'Shaughnessy, which was the difference in outcomes at 3 years in high 2 versus high 1 with the addition of anthracycline, indicating that high 2 tumors appear to be more chemosensitive, but as these these data show from Dr. Cobain's study, they also appear to have increased immune activation. Now, the prior response data of MammaPrint high 2 hormone receptor positive patients to immunotherapy have come from multiple arms of the I-SPY trial, in which I-SPY demonstrated improved PCR rates when immune checkpoint inhibitors were included with neoadjuvant chemotherapy, primarily in MammaPrint high 2 hormone receptor positive tumors rather than high 1. And here you see 3 of the immunotherapy arms in I-SPY, one with pembrolizumab added to chemotherapy, another with pembrolizumab plus SD101, another immunotherapy, or durvalumab, a PD-L1 inhibitor, combined with the PARP inhibitor olaparib. In each case, when you look at the comparison of the PCR rate in the control versus the immunotherapy or IO arm, in high 1, the improvement was 1 to 7% only, while in high 2, there was a doubling or tripling of the PCR rate, as you can see there, from 45 to 66% compared to the control arm of 21 to 22%. I think it's also important to note here, since the control arm received only ACT chemotherapy, that this further supported the observation from Dr. O'Shaughnessy's trial that anthracycline regimens appear to improve PCR rates in high 2 compared to high 1. It was the data from I-SPY actually showing these positive results, which was the basis for the currently enrolling phase 3 randomized SWOG trial S2206, which assigns patients with hormone-positive HER2-negative MammaPrint high 2 breast cancer to receive either durvalumab plus neoadjuvant chemotherapy versus neoadjuvant chemotherapy alone. The schema for this trial is shown here. Patients must have clinical stage 2 or 3 hormone receptor positive HER2-negative breast cancer, and they may enter the trial through having had a standard of care MammaPrint test, which yields a high 2 result on a needle core biopsy, with the score being between minus 0.57 and minus 1. And then they may be registered and randomized to this trial, or they may consent to the trial before obtaining a MammaPrint and be registered for screening, which if they are found on needle core biopsy to have a MammaPrint high 2, they can also be enrolled. The randomization, as you can see, is 1-to-1 between standard of care ACT neoadjuvant chemotherapy versus ACT plus the PD-L1 checkpoint inhibitor durvalumab, followed by standard of care surgery, radiation, endocrine therapy, and possibly targeted therapies such as CDK4/6 inhibitors at the discretion of the physician, with long-term follow-up planned. Now, the basis of this study, of course, was the observation in I-SPY of improved responsiveness of MammaPrint high 2 to immunotherapy. Hence, the study objective here was to characterize the underlying biology that is mediating this immune therapy response, looking at a variety of measures of immune activation. One aspect of this study was to characterize the clinical and pathologic features associated with MammaPrint high 2, to evaluate gene expression levels that define the immune biology of high 2 versus high 1, as well as to look at the further stratification by blueprint subtyping into luminal and basal subtypes within the high 2 category. And then using gene expression profiling from the FLEX database to analyze innate and adaptive immunity cell types, as well as antigen processing and presentation pathways, and also expression of PD-1 and PD-L1. The methods shown here involved analyzing 2,916 patients from the FLEX database with hormone receptor positive breast cancer, stratified, as I mentioned, within the high risk range to be either high 1 or high 2, and then also stratified within the high 2 category by blueprint as either luminal or basal. And then immune characterization was also conducted based upon gene expression to compare high 2 with high 1. Immune cell abundances were defined by the gene signature-based method known as X cell, and differences were determined by the t-test. Gene expression of the Kyoto Encyclopedia of Genes and Genomes, the KEGG pathway genes for antigen processing and presentation, and the expression of PD-1 and PD-L1 between high-risk groups was determined by the use of the R-packaged lemma. Looking first at the clinical characteristics in this particular cohort, 79% of the tumors were MammaPrint high 1, 2,292. 21% of the tumors, 624, were MammaPrint high 2. The patients who were high 2 were more likely to be younger compared to high 1. And they were more likely to be grade 3, although in this particular case, the details about grade are important. 30% of MammaPrint high 2 patients were not grade 3, but were actually either grade 1 or grade 2. And of all the grade 3 patients, 53% were high 1, not high 2, illustrating that grade, in particular grade 3, is not a specific surrogate or correlate of high 2 MammaPrint. In addition, MammaPrint high 2 tumors were more likely to have low estrogen receptor staining. However, 83% of high 2 patients had estrogen receptor positivity greater than 10%, and therefore not in that low ER category. So looking initially at the innate immunity, immune cell abundance based on gene expression profiling, it was observed that MammaPrint high 2 tumors had significantly higher abundance of antigen-presenting cells, APCs, compared to high 1 tumors. And here you see the difference in M1 macrophages and activated dendritic cells. Also, compared MammaPrint high 1 to high 2, there was a higher abundance of natural killer cells in high 2 patients and a significantly lower abundance of neutrophils in high 2 patients compared to high 1. I'll also call your attention to, within the high 2 group, the difference between luminal and basal. In each case, for the most part, whether a tumor is luminal or basal, the high 2 tumors showed increased innate immunity in nearly all categories. However, the activation seemed to be greater in the high 2 basal tumors. Now, looking at the antigen presenting and processing pathways through the KEGG analysis, the genes involved in major histocompatibility locus 1 and 2 pathways were upregulated, shown in red, in high 2 tumors compared to high 1 tumors, significantly increasing the activity of antigen presentation and processing. Looking at PD1 and PDL1, there was also a higher expression in high 2 than high 1 in both PD1 and PDL1. Turning to adaptive immunity, the same increased activity in high 2 tumors was also observed. Compared to MammaPrint high 1, MammaPrint high 2 tumors had significantly higher frequency of CDK4 positive T and memory cells, shown here, both luminal and basal. CD8 positive T and memory cells, again, both luminal and basal high 2s. And then for B cells, memory B cells and antibody producing plasma cells, there was a consistent increase in high 2 compared to high 1 in both luminal and basal tumors. So in conclusion, from Dr. Cobain's presentation, MammaPrint high 2 tumors exhibited a heightened immune active state compared to MammaPrint high 1 tumors among those that were hormone receptor positive, HER2 negative, early stage breast cancers. The presence of immune cells and the upregulation of genes involved in antigen presentation and processing, which are critical in eliciting a T and B cell activation and anti-tumor response, may actually explain the improved response rate to immunotherapy that was observed in the I-SPY trial in the MammaPrint high 2 tumors, and of course justifies the inclusion in the SWOG trial of the MammaPrint high 2 classification. As mentioned in the initial slide, selecting patients with hormone receptor positive, HER2 negative early stage breast cancer for immunotherapy treatment based upon grade or percent estrogen receptor positivity alone may exclude patients likely to benefit. As you saw from the data here, there were a significant proportion of high 2 patients that were not grade 3, and the majority of high 2 patients had over 10% expression of estrogen receptor by immunohistochemistry. Conversely, patients with higher grade tumors, specifically grade 3, were not always high 2, and at least from the I-SPY data, would not have been expected to benefit from immunotherapy, despite possibly being exposed to the toxicity of such treatment. And as mentioned, these data, based upon a translational analysis of the immune activation state of hormone receptor positive cancers using MammaPrint high 2 as a selection criteria, these data support the ongoing SWOG S2206 clinical trial in evaluating the impact of neoadjuvant chemoimmunotherapy on the rates of pathologic complete response and, most importantly, invasive disease-free survival in hormone-positive, HER2-negative early-stage breast cancer identified by MammaPrint as being high 2. Now, I think there are some important takeaways that I would like to emphasize from Dr. Cobain's presentation that I'd like to review with you here in a moment. What I've shown and what Dr. Cobain's data have shown is that MammaPrint high 2 identifies cancers with an active immune response. High 2 patients, as you saw, can be either luminal or basal by BluePrint subtype. It's important to remember that MammaPrint high 2 is not mainly low estrogen receptor 1 to 10%, with a significant proportion having a greater than 10% estrogen receptor expression. And these data may well explain why these tumors may have responded best to immunotherapy in I-SPY. They also support the decision by SWOG to use MammaPrint high 2 as a genomic biomarker for enrollment in that chemoimmunotherapy neoadjuvant study. They also suggest why MammaPrint high 2 tumors appear to be so highly chemosensitive as suggested by Dr. O'Shaughnessy's study. And it has been observed, as you know, that patients with heightened responsiveness to immunotherapy may also have increased sensitivity to chemotherapy for a variety of biological reasons. So thank you for joining us today. We are really delighted to be able to present these data provided from the Agendia Flex trial and presented by Drs. O'Shaughnessy and Cobain. We believe these data highlighted the value of MammaPrint high-risk data coming from the Flex trial. It also highlighted the integration of a genomic biomarker, MammaPrint high 2, into the NCI-supported U.S. cooperative group trial system, and further supported in these two important studies the value of the Flex study for seeking better outcomes for patients with breast cancer, whether it is to generate data to support decision-making regarding chemotherapy regimen choice, and possibly to help identify those women who may truly benefit from immunotherapy in the hormone-positive population. And as you saw, the main focus here has been on the high-risk range of MammaPrint, where there appears to be ample evidence for the benefit of escalation of therapy. Also, as you may have noted, it illustrated the added value of BluePrint in further defining MammaPrint high-risk hormone receptor positive breast cancers in terms of identifying primarily either luminal or basal subtype in this population. And taken as a whole, I think it's safe to say that these data suggest that MammaPrint and BluePrint are proving to be important biomarkers for guiding the use of chemotherapy, immunotherapy, and a topic not addressed here, but soon will be, endocrine therapy as well. I thank you for your attention, and I'm happy to answer questions.